I put together a case that I think will be a good sort of a discussion for us, and we'll cover, a couple of things. We'll kind of get to tease out from all of the experts on stage here what their sort of favorite rationale and treatment algorithms are, and then we'll go through our case, and then we'll kind of hopefully also kind of touch upon patient expectations and then how to co-manage some of these folks. And really, we treat these patients alongside every doctor of ophthalmology and doctor of optometry. We work together to take care of these patients. So that's the whole idea, is to try to get a good understanding of when should we be thinking about the higher level medications, and then how do we co-manage these patients if indeed they're at a stage where they might be needing some higher level treatment. So I'll just kind of, I'd like to kind of sort of start by asking you guys, and whoever just jump in, kind of, we've had so many comprehensive works on sort of, dry eye disease, DEWS 1, DEWS 2, the Meibomian gland workshop, ASCRS, and there's CEDARS group. So there's a whole bunch of literature out there. Can you guys, tell me, how do you not be how are you sort of not overwhelmed by all that, and how do you use some of these things to kind of, the most pertinent things that you've taken or gleaned from these really pivotal studies? Go ahead.
I'll start, sure. So, for example, let's take DEWS 2. I like to break it up into chunks, and I think it's fun to read. There are so many different aspects to it, so just taking one part at a time. As far as scleral lenses go, from DEWS 2, it's tertiary therapy. So that's really helpful in my practice when I'm explaining to my patients, well, we should try some conventional treatments first, and then we'll go to scleral lenses third.
Right.
I thought it was great how all of these algorithms and data. DEWS 2 is really very vast, and kind of, here's all the science, all the data, and here's some suggestions and things providers can do. The thing I like about the CEDARS and the ASCRS one when it comes out, when it's published, is that it delves into more what doctors should do and how to divide these diseases into subcategories and what therapies work best for some set of categories. So that's the thing I found very helpful, is how people think about dividing up the disease and different things to look for.
So with DEWS 1, we recognize that inflammation is a really big part of dry eye disease. While it may not be pertinent in every example, it is definitely part of the cycle. I think that, as you highlighted, what we are seeing with all these different algorithms and pathways is dry eye is extremely complex. It's complicated. Symptoms and signs don't always match, but we're learning more. And the purpose of these different algorithms is to help us pick and simplify and understand first order, secondary, tertiary, both in severity levels of disease as well as how to order our management options. DEWS 2 was really important because it really highlights the importance of the neurosensory component, that explains why younger patients are often so symptomatic, but they often won't have much in the way of staining because they're able to compensate, versus the opposite end of the spectrum, as Eric pointed out so eloquently, in our older patients, because that subbasal nerve plexus is destroyed in the cornea, they're often asymptomatic, but we see a lot of signs. With that being said, the CEDARS Aspens is quite nice in that it offers options that are a little bit more exotic in treatment, some of the more compounded options for therapy, so there's much more therapeutics there. And the cornea committee one from ASCRS is really good because it does truly simplify what to do in the setting of the specific cataract and refractive patient, and kind of the acute preparation as well as how to manage those patients. So they each have a lot of pearls. They're all very rich, and there's a lot of commonality amongst them, but I've found that those are some of the different highlights where they are different and unique.
Sure. Right.
We may not all share the same sense of fun that Dr. Barnett does in reading DEWS 2, but It's a 433-page document. However, like she said, you can break it down into chunks, which make it digestible. So there's categories about the definition, the epidemiology, the diagnostics and therapeutics, and I think that's valuable to just take it in bite-sized pieces. DEWS 2 really says we have to look at the symptomatology of the patient as well as the signs, and as Dr. Yu said, you know, there may be a discordance in the signs and symptoms, so looking at both of those is important. Using survey, as Dr. Donenfeld said in the first component, it's really important because it gives a number to a feeling for our patient, and that's what DEWS recommends, as well as looking at our diagnostic signs.
I think that because of the fact that you've got such a wide variety of managements and treatments, what it shows you is that there's a bunch of different things that might work for a specific patient. And so what I find most challenging, and you know, in the early stages that we're, you know, that Ahmad wants to kind of move past that to talk about, you know, it's fairly simple and straightforward. You know, you can use a little rinse in your lids and a little tear whenever you need to, kind of thing. But as you get up into the more complicated patients, a big part of it is really reinforcing that this is a chronic disease that there's not really like a cure for, and then trying to balance, are you going to do something at home, or are we going to do something in the office, and how good or bad you feel or how good or bad you see. And so I find for each patient, the fact that you've got all of these different managements and treatments, having all of them in kind of your toolkit or whatever can help you to balance it for that specific patient. What's going to be the right balance of comfort and vision and compliance and cost, et cetera. And that's why I think having knowledge about all of those things is going to be helpful.
Good. Very good.
I use these algorithms to refine and double check my approach to dry eye. You know, mine is a heavy contact lens base, as is Melissa's, but it helps me evaluate where I'm at with my treatment protocols and if I'm still on point to where I should be. And so again, you know, taking those chunks with parts where maybe I feel like I'm weaker or stronger in my diagnoses and management strategies, it helps me kind of refine what I'm doing and making sure that I'm keeping up with the current standards. And so rather than taking them like, you know, for word, you kind of have to look at them all, see how it applies to your patient base, because we all have very different patient bases up here, and make sure it matches up with what you need to do for your patients.
Yeah, and I'll echo that. I think the way that I approach them is more from a macro level as well, because these are, you know, guidelines and algorithms to help us with our patients, but all of us do have a little bit of a different patient base. So I try to look for commonalities between both on the diagnostic and the management strategies. As Liz said, inflammation, I think, is one of the biggest commonalities that we've really recognized in the last 2 decades. And so generally speaking, for most patients, it's a good approach to start with, and then we can kind of tailor it down there based on what we see under the slit lamp and with our other diagnostics.
And I'll make a comment as well, and that is listening to everybody. I think everyone had very good points. The key for dry eye management is diagnosing the disease and caring about it. If you don't diagnose it and you don't care about it, the patients don't get treated. So it starts in your office with you. That's number one. Number two, there are a couple of very simple concepts of dry eye that I hold to be self-evident, and that is that you usually start with tears. And there are some good tears that I find very good, and you know, I get the patients to move away from things like Visine, Nafcon A, and get them on a good tear. That's just a universal. Omega-3s work on everybody. I work on aqueous deficiency and meibomian gland disease, so I really do like omega-3 therapies. It's a bedrock of my therapy, and I love the holistic approach to that. I know it's self-evident that corticosteroids make everything better. They make meibomian gland disease better, they make aqueous deficiency better. So I use them on very symptomatic patients right from the beginning, all the time, for short courses, not for a long time. And then I develop my therapy, and I don't really follow a significant guideline. I use what works in my hands, and you'll find what works in your offices with your patients. And there are so many good therapies, but don't be afraid to use immunomodulation earlier on. Don't be afraid to talk to patients about meibomian gland disease and some of these new therapies like iLux and tear care and LipiFlow. I mean, patients who are really symptomatic will appreciate that, and it almost helps everybody. So talk to patients about the disease, develop therapies that work in your hands, and get your office to buy in on your therapeutic so that everyone's working on the same page, and I think that's very helpful.
And I think this, oh, thank you, the mic is working now. This group in this room, I think, is unique because everyone's here because they care about dry eye,
Right,
which is
right.
amazing. But I think we have to go out and teach our colleagues and really stress the importance of both diagnosing and managing the condition.
One more thing about DEWS 2 I found really useful, and something I'd been preaching for years was that we've been dividing up these diseases into categories, but DEWS 2 is really good about saying these categories don't live in isolation. And I think that's something I see, especially young doctors and students that I work with, as it's meibomian gland disease, it's only meibomian gland disease. And Eric spoke to this morning, that we have to realize that meibomian gland disease has effects on aqueous and mucin, and aqueous deficiency disease will have effects on meibomian glands as well. So these things are all interconnected, and I think we're all good as eye providers seeing that interaction between the dynamics of the lid and the aqueous and the cornea and the conjunctiva, and I found that really useful in the DEWS 2 to say, yes, these are related, and don't let them live in isolation.
Yeah. That's perfect. Thank you, guys. Thank you. Good. So we'll go ahead and kind of go through the case here, and I would just say one brief comment on all of the excellent points you've all made is that because it's such a multifactorial complex disease, I find that the more people I kind of talk to about that patient, whoever has their hands involved in that patient's care, their rheumatologist, their dermatologist, the more I kind of connect with those folks, in the end, that really helps with patient outcomes too. So they gotta have an idea of what. So sometimes they just kind of get in their own silo and don't really think about their eyeball, but just picking up the phone and talking to them about the patient really helps. So this is a patient that I had seen like 5 years before this actual visit that we'll kind of go through. And so, so basically this is a patient that came in on a sort of urgently. She's 39 years old. She has lupus. She's also a Sjogren's patient. She's hyperthyroid, has anxiety, and is on a bunch of anti-anxiety medications, has allergies. So really a list of several things that are kind of a bunch of red flags. And she came in urgently in my clinic. She doesn't wear contact lenses, and she's not taking her Plaquenil, which was prescribed, and she's coming in because, was doing well, and then the winter hit in Minnesota, and then she tanked. So she's got really a lot of burning and gritty sensation, really, not able to really function very well because her vision's all over the place. And it started 2 months ago, and she's really sort of at the point where she's, again, coming in urgently. And so she has Sjogren's, pertinent history that was already in the chart before I saw her. She has Sjogren's, ABMD, evaporative dry eye, and blepharitis. So this is the kind of patient that we see all the time. She sort of has a bunch of systemic things going on. She's been, treated in the past to a certain level where she might have been kind of, holding her own, and then all of a sudden a bunch of things happened and she's a lot worse. And you're the dry eye person, so I need to leave here feeling better. So here we go. So this is the kind of thing that happens frequently in our practices. So this, when she was first diagnosed, she was prescribed 3 different eye drops and an antibiotic. So that's kind of was an important thing for me because this is not a sort of an entry level. She was prescribed a bunch of things to get her better, and she's been off of those things recently, and her symptoms started 2 months ago. And now, of course, she's on, refresh every hour because that's the thing that kind of gets her through her day. So these kinds of patients come in more frequently. This is kind of a quick summary of my slit lamp exam with her. Visual acuity is 20/25, her left eye is worse, 20/30. She has a low tier meniscus, an incomplete blink, a little bit of allergy, papillae. The puncta were open, there's no eyelid malposition. She had kind of moderate amount of telangiectasia. Her nerves were healthy. Her inflammatory was strong positive, and then osmolarity was in the 330s. and speed was at 21 out of 28. And so this is all a kind of the sort of the entrance, kind of our pieces of information that we had. And then her LipiView showed some decreased tear film lipid layer deficiency, and she's right around 30 or so on both sides. Okay, and then this is her meibomian gland imaging. It's not horrible. There's some glands there, So there's cases where you think, oh my gosh, this patient's really symptomatic. I'm not going to see a gland, but they're there. But her tear film lipid layer deficiency is down. So my slit lamp exam, I try not to do what Eric warned us to do. Never just go past the lids, look at the lids, and take a look. She's really, really symptomatic. So if the quality of these pictures is bad, it's her fault. No, I'm just kidding. No, it's absolutely my fault. But so there's some telangiectasia, obvious telangiectasia along the lids. And then I'll just run through a series of the next couple of pictures of her cornea. You guys don't get to see the pictures. The monitor's only over here, I'm sorry. But you kind of see a bunch of epitheliopathy. This is her left eye, which was more bothersome for her. I'll kind of stop at that one there. Can you kind of see the, okay. And so I'll kind of stop at that one there. Out of all of that information and kind of some of these pictures, what are you guys thinking? And, as far as, assessment plan, things like that.
Well, I'll start with this one. The thing that strikes me is, number one, she's got underlying autoimmune issues. She's obviously got a lot of ocular surface desiccation that leads to further inflammation. Her lids are inflamed. I mean, here I think that this is one of the cases where we look for commonalities. And the first thing that I would need to address here is to try to decrease her inflammatory load so that things can start to function a little bit better. Fortunately, she hasn't had a lot of tissue loss in her meibomian glands. The anatomy at least looks good, but it may be suppressed by inflammation. So my first step with somebody like this is to get them on steroids and then maybe also a kind of a more gentle immunomodulator, assuming we can decrease that and try to transition her onto that over the long run.
I agree with what Scott said, and I would probably follow up with beyond the ophthalmic therapeutic, track. When I look at those lids and I see the telangiectasias there, it makes me think of using something like intense pulse light to minimize that, and perhaps followed by a thermal pulsation of some sort to really push the glands out. Using IPL can mitigate inflammation in the tear film to a degree, but it can also be promotional for removing the obstruction, especially when it's followed up by a thermal pulsation.
For me, one of the keys in this patient is that she had previously been pretty well controlled and then got out of control. And so in kind of back to my earlier comments, I think the compliance aspect of things and helping patients understand that just because they feel good, that they're not cured and they don't need to stop their stuff that they were doing before. And so going back and looking historically, what worked before for her, and getting her back at least on those things that had worked and that she had tolerated. And then I guess I agree here too. You probably need extra steroids and a variety of other things. She has filaments. I think on that last picture is what I saw. So then the comfort aspect of that, trying to figure out if that's the reason why, and then also the fact that it's now wintertime. Kind of modulating the environment around her. And so talking to her a little bit about screen use and the humidity in her house and kind of the cloud of humidity right around her with a little personal humidifier. Those kinds of things can sometimes get you up and over the bump, in addition to other things that are going to be helpful in the long run.
So that's actually what I was going to touch on, is all the lifestyle aspects for her. So I completely agree with the comments. Of course, we have to address the eyelids, we could do a variety of methods actually to successfully treat her. Increased tear production, but also let's talk about her day-to-day, computer use, positioning on computer, drinking water, goggles, even daytime moisture release eyewear, nighttime eyewear, humidifiers at night definitely, perhaps during the day as well. We can talk about diet, we can talk about omegas. So there are a lot of other things to add in for my patients with Sjogren's that really help.
So this is, oh wow, this is obviously a pretty hot eye. She's coming in acutely flared, and whenever I look at a patient like this, at least we have signs and symptoms that correlate. So the conversation is easier. She recognizes that the disease is there, so the conversation piece of this is something that will always require some level of therapy, even after we get you past this flare. But beyond that, that it's not going to be that one treatment is going to take care of everything. And when I look at treatments, I kind of put them into 3 silos. The first one being kind of systemically, what can I do? And she has so many different risk factors, even with her antihistamine use. Loratadine, which is a more selective antihistamine, 4 days of that has been shown to decrease aqueous production by 40%. So as Dr. Donnenfeld had mentioned earlier, even if we can kind of do a better control of that, moving over to mast cell stabilizer orally, maybe nasal steroid followed by a nasal antihistamine like azolestine could be more helpful, at least to see what we can control from a systemic standpoint. And then 2, obviously, how are we going to normalize this tear film, starting with a steroid? Because she has filaments, we don't want to use anything real mucoid or suspension that would further exacerbate the filaments here, but considering more like a solution to like dexamethasone solution, something preservative-free. So at least if we are using an anti-inflammatory, we're also not worsening the filaments, not 2 steps forward, 1 step back. So thinking of our choices there, and then figuring out here, there is a chronicity to her lid margin disease, and we're fortunate that she's got great architecture. The telangiectasis definitely demonstrates that the inflammation has caused the telangiectasis to form. So there's a chronicity there too. And so I absolutely agree there. And third, that leads into how can we improve the architecture of our ocular surface? And here it would really be, it sounds like maybe EBMD treatment in the future, if that is exacerbating her evaporative component, as well as managing that lid margin, first diminishing the telangiectasis by IPL and controlling it, and then maybe kind of following it up with maintenance and routine thermal therapies to help what she has, which are a great existing glands. So really utilizing that, since there is that evaporative component too. But those 3 silos, not doing everything at once, but kind of tiering it along the way, but first quieting it down with the flare, knowing that patients have flares routinely. She's obviously in a very severe one.
Would you remove the filaments?
I like to debulk them,
Yeah.
particularly in a patient like this who's so symptomatic, and that's going to cause potentially some of those filaments, if they squeeze hard enough, it can deepithelialize a small chunk too, because she's inflamed. She probably has poor adhesion, and she has EBMD, all risk factors for recurrent corneal erosions too, which might be another side component of what's going on.
Yeah, really severe patient here, and anytime I see filaments like this, I always, we have to address the cornea first and get them fixed. But obviously this patient needs a lot of anti-inflammatory help to rehabilitate this. And definitely agree with everything Dr. Yu said. With a stepwise approach to this, we've got to take care of the acute flare-up and then move forward with the other things to get the eye to be able to support itself. But when I see a patient like this, I'm worried that they're kind of standing at the edge of the cliff. Because we've all seen these patients where, they have this flare-ups, and then all of a sudden they come in with this persistent epithelial defect, or they come in with a pseudomonal ulcer because their surface is so unable to take care of itself. And so I worry that these patients are standing at the edge of that cliff where they're going to break down further, and then we're in real serious trouble where there's sight-threatening disease. And so I think being very aggressive and getting that inflammation addressed acutely with steroids and bandages, amniotics is really aggressive and needed and warranted in this case. And then the other things. But yeah, you got to kind of lay it out for the patient. Hey, we got a lot of work to do here. We're in a bad state. It's going to take me a while to get you back, but we got to do everything we can.
This is a patient where I don't think the therapy is as important. This patient's going to need almost everything that we have in our toolbox. What's more important for this patient is that the patient has to recognize that they have a severe disease. They're 39 years old, and they have vision-threatening disease at the age of 39, and they know they have this disease, and they haven't chosen to use their own therapy. So you have to have a conversation with the patient. I'll basically go into the room. This is the time where I spend more time with the patient than any other patient that comes in. I'll bring in my lead optometrist like you would come in with me, and we'll have a conversation about what they have, why it's important to be treated, and the natural history of doing nothing. And then I'll ask them why they stopped taking their medications, topically and systemically. And at the end of the day, this is going to be a conversation with the psychiatrist who prescribed the Zoloft, the rheumatologist who prescribed the Plaquenil, and you working together. And this patient, I would probably actually call the psychiatrist on a patient like this and tell them we have a patient with a very severe disease problem, and the patient has stopped taking their medications. And I need to impress on this patient how severe the disease is. Just as if I want to go to a therapeutic perspective, I agree completely with the steroid. This is a patient I'd use a steroid for a month, and I would start the immunomodulator, cyclosporin or lifitegrast, a week later. I wouldn't start it right away because of the burning. And I would think that this patient would need to be plugged on the next visit. And I would probably see if the patient was plugged and did well. I'd then do punctal cautery. This is a punctal cautery patient, not a plug patient from my perspective. I put them on oral omega-3s, and I'd use non-preserved tears, maybe along the lines of what she's doing. But most importantly, the conversation that you have to have with your patients like this is that you have a very severe disease. I don't want to overwhelm you. I'm going to start you on a simple protocol, and we're going to add more going forward. You may feel worse before you feel better, but we will work together, and the patient has to know that you are committed to working with this patient and that you will be a resource for them, and that together we will make you better, and you'll feel better, and you'll have a good prognosis. But they have to have a rapport with you, because if you treat them and they develop burning or irritation, they don't come back to you, you basically wasted their time. So you almost have to be a psychiatrist in managing these patients more than an ophthalmologist or optometrist.
I echo what Eric says entirely. I mean, the patient education in our mild to moderates is important about the disease process. But when you have someone who's moderate to severe who comes in, just taking this patient in particular and pausing and thinking, if that were you, we see patients every day. We see them for, 10, 15, 20 minutes, whatever. You're on to the next patient. But this is you living your life every day with chronic illness and chronic autoimmune disease, depression, and you go in and your eyes don't feel good, and it's really frustrating. And these patients come in looking for us to do something more. And to Eric's point, giving them sort of the straight story about it is important, but also giving them hope is important. And the hope component is not only the partnership that he said, but just knowing what your therapeutic goals are, knowing that they're going to be two steps forward, one step back, and knowing that you're going to be there to help them, and you're, as he said, going to be a resource. And it's really, really important. It's not to be understated, and I may be sort of repeating what he said, but it's worth repeating, and it bears repeating, because you guys are the people who are here, and you're the ones who are interested in dry eye disease, and they need you. These people are out there, and there's more and more of them. So being there for them is so incredibly important.
Just a few added points here. So this is where the Sjogren's Syndrome Foundation helps. They have literature, they have resources. I have so many patients with Sjogren's, and they're so happy, one, that I know what Sjogren's is, and two, I have information to help them. And I know I'm going to sound like a broken record over the next 2 days, but a scleral lens. I mean, in this sort of patient, you're going to be so sick of me, it's okay. But in this sort of patient, these are the patients where scleral lenses are life-changing devices. These are the patients that come in, they're suicidal because of their dry eye. And if you can get a lens on their eye, not in this acute stage, of course, but in a few weeks, you put a lens on their eye just in office, have them try it on. It's that instant relief. It's that, amazing. So I'm going to ask the help of all of you in this room to partner with rheumatology. And yes, we need to partner with rheumatology and dermatology and oncology and neurology to tell them what scleral lenses are. It's okay if you don't fit scleral lenses, I'm fine with that. But as long as you know the indications. But my own personal goal in life is really to work with rheumatology for all my patients that have Sjogren's and all the people that we can help so much. So yes, I'm going to be a broken record, it's okay, but we'll talk a lot about scleral lenses. But this is just the ideal patient. You know, get her in a scleral lens, in a few years she becomes presbyopic, add in a multifocal. We'll talk about that later today.
I was going to propose a question to the panel here, and the same thing. Of course, you know, a scleral lens is not indicated today because she is so hot, but patients with, you know, corneal filaments, ABMD, at risk for recurrent erosions, I mean, scleral lenses really do, I mean, they change lives, and they're just really an amazing tool to offer. And so I was going to just ask the panel here, and especially from the MD's perspective, when, you know, when would you feel comfortable with me instituting that type of tool for this patient?
Well, I think the scleral, I think it doesn't take very long to get things quieted back down again enough. The scleral lens is extremely helpful. So I wouldn't be uncomfortable in a week or two probably in this specific patient, because they're very uncomfortable. They probably have lost hope. You know, if you kind of look at why they stopped all this stuff, they thought it doesn't matter anyway. Maybe, I don't know. You'd have to probe into those reasons, and so being able to do things quickly to help them, I think, is very beneficial.
Yeah, in addition to that, this patient, as you mentioned, needs to be carefully or strongly educated that when she's feeling good, that means the treatments are working and she can't stop. And so in addition to scleral lenses, and it seems like a really big, time-consuming care regimen for her, but at this moment, you know, she needs to know that something that we would continue to educate her on is that she needs to keep everything that's been doing without the contact lens and the contact lens. And so it can be a little overwhelming to patients, but sort of breaking it down and how each piece of the regimen is helpful in maintaining their comfort can sometimes hit that home with them, that they can't step back because the scleral lens is comfortable. Now I can stop everything else. It's important that they know that they need to keep everything going.
And I would just comment that I really appreciate the doctors who spend the time to fit a scleral lens on a patient like this. It's really an amazing opportunity, and there aren't a lot of optometrists who do it. So, you know, we really have a special relationship with the people who do this, and I think it's really important. I don't think I'd start at 2 weeks. I think I would give the therapy a little bit longer to work, but I would certainly have this patient seeing somebody within a month or two down the line and see how they respond to the therapy that they're on first. But completely agree that it's an amazing technology, and how it's helped not just dry eye patients, but obviously keratoconus patients. I can't tell you how many patients I have who I thought I was going to do grafts on who are now walking around with 20/20 vision because of scleral lenses.
I think to some degree it's a little bit patient specific. If they started with contact lenses, this is a great option to discuss very early on. But I've also noticed once we get them stabilized and they're in the scleral lens and we've stopped this awful cycle, they're able to maintain their disease in a very, very good state with less medications than if they were not using the scleral lens, because the scleral lens itself offers so much in therapy, with the caveat being that I still talk to them about doing their lid blinking exercises in the evening, because any contacts, as we know, it can decrease the full complete blink. But beyond that, patients do so nicely from the perspective of the concha and the cornea. It's more making sure the lid stays stable and keeping them anti-inflamed, whether it's systemic or topical.
Well, I think the decrease in inflammation is incredibly important, and perhaps improving the obstruction as well through ophthalmics, through IPL, through thermal treatments. Those are sort of long haul things that take time to appreciate the improvement. You know, I've seen the actual posture of my patients change when they get a scleral lens, and you just see this sense of relief, and providing that barrier, to the outside environment, I think is important. It allows them the ability to feel that, I won't say exactly instant improvement, sometimes it is, and then maybe be more tolerant and open-minded of that long haul treatment regimen that we've set up.
I agree with everything everyone said. I'm a little biased too. I didn't write the book on scleral lenses, but I've heard of it. And I agree, a great tool. And I'd also comment that, when patients are better, it's a great time to start a lens. But also, we've all seen the data with persistent epithelial defects under scleral lenses improving. So if I saw this patient doing everything and doing what we're asking them to do and getting worse, which I think we've all seen, that might be a time to institute further therapy, which might be a scleral lens. I've had several patients where they're doing everything they're supposed to, and their epithelium's still getting worse, and had great success with these persistent epithelial defects. On that note, it'll be very interesting to see how oxervate plays a role in those sort of patients in the future, and also using the scleral lens as a drug delivery device, especially for autologous serum. I think that pairing is just amazing. Using autologous serum inside the scleral, and the scleral as a delivery route is awesome.
Good.
Question over there.
Yeah, go ahead.
So topicals, IPL, automated thermal treatments, scleral lenses. I've added it up, and we're $3,000 to $4,000 maybe for the patient. How do you talk about this, and how do you keep them not turning white in the face? How do you keep them coming back and realizing that they have to invest a lot of times out of pocket, this is not covered, or Restasis, they said it's going to cost me $500 a month. How do you deal with the fact that there's a lot of money involved?
I'll start with the scleral lens aspect. I like how you added all that up. That's wonderful. But scleral lenses, if they have medical or vision insurance, would be covered with a medical diagnosis. So the fit and materials, if they have general insurance. If they don't, that's a whole other story. But oftentimes in a patient like this, it would be covered.
And this is the type where a typical scleral lens for vision correction, the V code is different from when you use it as a barrier. And so at least on the practice management side of things, insurances do reimburse us a little better for the V2627 code, which is the barrier. And so it does make it a little bit easier. You have to have very specific documentation and careful note-taking to justify that, because it is a little bit higher code to be audited just from the practice management side of things, but the V code for a barrier is a little bit easier to deal with on the practice management side of things.
I'll just mention also that eye care professionals tend to undervalue the importance of vision and the cost associated with it. I go to the dentist, you have one tooth pulled and have an artificial tooth placed, it's $5,000 for that one tooth, and no one seems to be upset about that. Yeah, this is a patient with very severe disease who you're going to be spending a lot of time with, who needs a dozen different modalities. I think you give the patient the best treatment you can give them, and you give them the opportunity, and you explain to them very openly about the costs that's associated with it. But you explain that this is not a normal case, and it's going to need a lot of different therapies. But you start with the simpler things, and you work your way up, and you let the patient know that you'll be cognizant of the cost, but at the same time you want to do what's best for them.
I'm going to echo that and then also stress something that Dr. Harden mentioned earlier on. And really, when we're talking about chronic disease, you've got a couple of different buckets you can fill. I mean, one is how much money they're going to spend to control that. Number two is how good are they going to feel. And number three is really what is the overall health for their eye. We have to balance that. So I'd stress what I think is the best treatments for the patient at the time, and understand that there may be times where they're going to be spending a little bit more money, but if that's outweighed by the health benefits that they get and the preservation of their vision and their ocular surface, I think that's something that we need to do a better job of conveying. Most patients will understand that. If you're really advocating for them in terms of vision preservation and health preservation, they're going to find a way to make it work, and you can work with them as their advocate to make it happen. But as we get into more of maybe a stabilizing or a more stable phase, then it becomes a choice of, okay, well, are we going to spend money on our omega-3s, or are we going to spend money on our, Restasis or whatever to try to keep your ocular surface going? I mean, that's when I think those conversations get a little bit more nuanced. But in the beginning, you give them what you think is the best to get them stable.
I actually think this is an easier conversation with this patient than it is for our mild to moderate. We know where those patients are going. We see that. We see, oh, I know I can help you, but they're not asymptomatic. This patient, probably, considering immunologic, systemic, rheumatologic things that are going to meet their deductibles in a week. So that helps if you want to look at it that way. But this patient has sight-threatening disease, and usually I'm going to go back to that conversation with the patient that they are on the edge of this cliff. I can help you. We need to help you to save your vision. And typically, the more acute things we do help and show the patient that we're on the right road, but also tend to be less expensive. I mean, there are steroid options that are not that, are very cost effective. And so the initiation of that stuff isn't really a hindrance, in my opinion, for cost. Now, next steps can be, but you've gotten that patient rapport, you've gotten that patient better, and then we can move forward. So even simple things like bandage lenses too are sometimes recognized, underutilized, and inexpensive.
The other thing that I forgot to mention is that because a lot of what's going on here is likely related to their immune disease, getting them back on track from a systemic standpoint, I think makes our job much, much easier over the long haul. So stressing that they really need to be compliant with their rheumatologic regimen and making sure that we communicate that with rheumatology and then psychiatry as well, I think also makes the patient a little bit easier to manage. And once we get those things on board and their systemic disease is controlled to a better degree, we have to worry a little bit less about how their eye is. I mean, again, it's just more maintenance at that point.
And for me, a couple of things. One, the reason that the plan is so important, that you tell the patient about the plan, is it's not, well, we tried this ophthalmic medication and it didn't work, so now let's try IPL. Well, now let's try thermal pulsation. Having the roadmap laid out, this is what I'm going to do, this is why I'm going to do it, and I think it gives them a sense of direction versus, well, that one failed, I'm going to try something new. I think it gives them, again, a good overview of what you're planning. The other thing in your comment that I would caution you about, and caution everyone about, and it's sort of a passion point for me, is sometimes patients acknowledge and hold on to the price that's on the sticker from the pharmacy, not really what they paid. Very few patients pay $500 for cyclosporin or lifitegrast, very few. So when they come in and they tell you, well, I paid $500, ask them, is that what you paid or was that what was on the bag? Because that's probably not the case. And then we get this misconception that these medications are completely out of our patient's price range, and nothing could be further from the truth.
Good point.
I was just going to say that one of my biggest challenges, and I don't know, you were saying about how the most of the sclerals, Blue Cross in Iowa won't even pay for a contact lens for a keratoconus patient. So, so we've got the challenge I'm running into is I don't have any of the next steps available for a huge chunk of my patients that is anything covered. So if you're saying I got $1,000 for a scleral lens, or I can refer you for IPL for $1,000, or we can do iLux for $500. You kind of start going, all right, and the biggest decision that, and they all have high deductibles, by the way, and they all come in January. So, right? Because that's just how it happens. So,
on a Friday?
Yeah, pretty much. We've got a few of these, and I find that I'm having to have the conversation, New Lids is great. It's $300. iLux just upped their tip prices. They all are big. There's nothing under $300 to $500. So I find the biggest challenge with some of the new things coming out is what can I do if they've got this much money to spend, choosing which therapy I think will work the best to give them the most bang for their buck. I hope that they'll continue on and do all of them. But I got rosacea is a huge, so you're looking at the telangiectasia, so which do I choose first?
There's a couple of cost-effective therapies is that if they can't afford to spend $1,500 for a lid treatment, oral doxycycline costs about $10 a month and works really well. Corticosteroids work really well, and generics are very inexpensive. If you're talking about immunomodulators like cyclosporin and Xiidra, if the patient doesn't have insurance, my experience with the drug companies is this is one of the times when they will give it to you, and you just have to write a letter and you can get it for free. And then punctal plugs cost almost nothing. So these are mainstream. These are therapies that can be very cost effective, and I think it's very important as a doctor to weigh these and have a conversation with the patient about the risk reward and the benefit ratio for the patient. But there's a lot that you can do economically.
Yeah, and then next level, oral omegas, there are certain that work extremely well. Yeah. Hydra Eye and PRN are extremely effective in that they're additive too, because it'll address both sides. So beyond the in-office procedures, amniotic membrane therapies, whether it's drops or extract, works very, very well as an anti-inflammatory, as well as promoting the healthy growth and stimulating stem cells. There was one by Ocular Science that was out. It's not available right now. I know BioTissue is working on one, but I've had, because those two are not available, Regenerize I've been using. I've got no relationship with them at all, but it's done very, very nicely as an amniotic cytokine extract. They use it twice a day, and it's $500 for a 3-month supply. And the company is a smaller company. They're extremely responsive, and they follow up with the patients. And so while that's a price point that's not an insignificant price point, but it can be something that's more manageable because it is similar to what copays may be, and the two anti-inflammatory immunomodulators sometimes do have the side effect issue, whereas the symptomatology relief does occur a little bit quicker on that curve.
And I'll speak with you later offline about the insurance in Iowa.
I'm gonna
I will speak with you offline about the insurance in Iowa.
I'm going to just flip the mood a little bit and say, I'm going to be a little glass half full here, and I'm going to say, isn't it an awesome problem that we have all these great options for patients now? 5-7 years ago, we were saying, yeah, you got to take your steroids, you're going to get a cataract, might have to manage your glaucoma. And now I'm like, well, I've got this and this and this and this, and we have a lot of options, and we're going to treat you, and we're going to take care of you, and look at all this awesome technology I can offer my patients. Yes, there's a cost and involved with that. If everything was free, I don't think any of us would be working. But isn't it awesome that we have all this good stuff now? So yes, good advancement. We're making progress.
The other thing I was going to mention on kind of the long-term management of these patients is that if you can keep their meibomian glands healthy, then also, 20 years later, you don't have the problem of seeing that horrible dropout like was in one of Eric's slides. And those are really, really challenging patients to take care of because of the fact that they don't have any reserved meibomian gland function. And so I think we're going to kind of balance the short and long-term costs as we move through the next 5 to 10 years, having had meibomography in imaging, because we'll be able to see. It's the same thing as, do you just get dentures or do you keep your teeth? There's the whole thing about that, and I think we'll be more challenged with trying to say, now we know in 5 years you're going to be in big trouble, so we need to spend a little bit of time, effort, money, whether it's doxycycline or IPL or Lipoflow or Ilux or whatever it is, to try to keep those glands healthy over time.
Keep in mind, from a financial perspective, patients can also use flexible spending for a lot of these out-of-pocket expenses. So talk to them and say, have you set aside some flex dollars? Because to the point that was raised, a few minutes ago, I mean, the crown is $1,200. It's nothing to sneeze at, but nobody asks questions. So.
I thought it was $4,000 for the crown.
Cyclosporine that I was asking Dr. Donenfeld about, it's $150 for a 90-day supply. So your staff will love it because no prior authorizations.
All right.
So it's the question.
That's pretty cost effective too, $75 to $130 a month. A lot of people.
Yeah, a lot of these times as I'm tapering down or stopping the steroid, we are introducing autologous serum as a replacement neuroprotective inflammatory modulator.
I might lean on what Dr. Yu said and using something like an amniotic tear.
Good.
Fantastic. I'm sorry, go ahead.
Going back to this patient and not overwhelming her and supporting her and not making her feel like this is hopeless, that first appointment and also wanting to quiet everything down, how much would you start with? How much education, how much therapy first when you add ramping up?
I believe the question was how much therapy at the first appointment when you see this patient coming in. What are your first things you're going to do at the first appointment?
Well, I think you can go back to whatever she was on before that controlled her, and then recognize the fact that controlled disease, when it was not hot and quiet, and then add whatever else additional that you feel like it's going to. So I think this patient can tolerate a lot more stuff to start out with, because what you want to do is put her on enough stuff that you think that she is going to be better when you see her back again in a couple weeks or whatever. Because I think if you go, we're going to try this thing, and then a couple weeks later we're going to add this and take away this, or get the thought process that one thing's going to take care of it or it's going to cure it, or like somebody mentioned, you know, that didn't work, so now we're going to do this. I think that here you're going to have to hit it from a bunch of different target points. So this specific patient can tolerate a lot of that, you know, lots of stuff at once, whereas some can't if they've had, you know, they're coming in for the very first time or the second time, or they, you know, so you have to look at that specifically based upon their past history of medications. That's why it's very helpful for that.
I might start the patient on 3 or 4 treatments, but what's more important than what you do, it's what you tell the patient. So what I'm going to do here is I'm going to say, I'm going to start you on steroids the first day, and I'm going to stop it next time you come in. So they know that it's not that it's not working, it's that this is part of the plan. And then I'll tell the patient, on my next visit, I'll almost certainly do punctal plugs on the next patient. And I probably wouldn't do serum tears on the first visit, but I would definitely do it on the second visit on a patient like this. So what I tell them is, this is what we're doing today, and next time you come in, this is what I'm going to be doing. Because what patients get upset about is when you change therapies, where you think that you're changing therapies because it's not working or they don't trust you. If you go in with a plan and you outline what you're going to do today and what you're going to do tomorrow, they trust you more than if you kind of don't set the proper expectations for them going forward.
I think it's very much patient dependent. So in a patient like this, they're coming in with an acute case, and I like to start a whole laundry list. I like to start everything. But for patients that can't handle it, and I know that they can't, I won't start everything all at once, and I'll see them back, and then with plans. Sometimes I don't even tell them because I know they'll get too overwhelmed. You're going to have me do 6 things. I can't do 6 things, you know. And so in these patients, they're very symptomatic, and this is really affecting their quality of life, their day-to-day, you know, just how they're functioning. So I'll give them, depending on the patient again, you know, some patients I can give them everything. They're very compliant. They do very well. Other patients, I'll give them part of it, and then I might say, oh, we'll see how you're doing, and I might add some more. And then when they come back and you've developed that rapport with them, talk to rheumatology, develop that relationship as well, good. Then I'll see them back and add more. So it does depend on the patient.
You know, as Dr. Barnett was saying, it's really about reading your patient. Read your patient. And you do this very quickly, instantaneously almost. You come in the room, you can see their posture, you can see how much they're engaging you, how, you know, why did you quit your treatments? Was it because it wasn't working, because you couldn't afford it? I mean, have frank conversations with them. But, you know, a colleague of ours, Dr. Kathy Mastrodas, says everyone has the 2 best diagnostic tools in their office, and it's your 2 ears. And nothing could be further from, or nothing could be more accurate. Hope Kathy's not in the audience. So, you know, the thing is listen and look and really take in what they're sending out to you, both verbally, but also just from body language. Because, you know, you can lead a horse to water, but you can't make them drink. And some patients are just not going to do it, and they're not going to buy in. And, you know, we need to be the good doctors for them and educate them, but some of them aren't going to follow our instructions. Others are dying for it. They will be the ones who will want every bit of your attention. And, you know, I think we just have to really see what they're sending out to us.
Perfect.
Can we put the doctor on the spot? And what did you do for this patient?
So Lotemax, Helon, doxycycline. And you guys, I mean, it's amazing the level of, I did not discuss this case with anybody on this stage. So it's really, you know, the level of precision that you guys just, you know, displayed and kind of really parsing this out is really phenomenal. So Lotemax, Helon, doxycycline, and the reason why Dr. Harden-Shee sort of, you know, got to where she is now is because of her anxiety. You know, it was just like she felt, just like you said, she was kind of like, well, I have so many things going on.
So did it take you a whole hour to decide on that when you saw her in the office, or was it a little quicker discussion than our discussion?
That's why I run behind. Yeah. But I learned that from you, so.
So the one that I think that's great, Ahmad, because I think a lot of us were thinking the same things. I mean, if we're looking at Lotamax and doxycycline alone, I mean, you're controlling the lids, you're controlling inflammation on a couple different levels. The one thing that I probably would have added, if this was a new patient to me for the first time, might have been a draw for serum, just because one in Colorado takes us a week to get it processed. But as a Sjogren's patient, we know that her glands likely aren't functional, and when we have a dysfunctional lacrimal gland, we're not getting the stuff into the tear film that's going to really support the surface over the long haul. So getting them ready to phase into that, where we can decrease the steroid and add in serum, I think is helpful.
Absolutely.
But I don't know, with her anxiety, I'm not sure, did you have a discussion with her about serum? Because some patients really have a hard time with that as well. So.
Right, blood draw and stuff like that. So I stepped away from that conversation because I wanted to develop a long-term game plan with her, and I really focused on her glands. I said, look, this to me is the silver lining. These are not gone, so this is fantastic, and you're 39, so we have to outlive this thing, and we're going to get you more comfortable. So it was all about exactly what you guys just laid out, kind of developing that strong relationship and setting a long-term, sort of a long-term game plan.
You know, you joked about, did it take an hour to see this patient? These patients can be time-consuming if you allow it. I would suggest you create your narrative, that your structure, and then you can tailor that. But be ready to educate, be concise with your education, but specific. And really work through your discussion in your mind before you go see these patients. So I would encourage you to really create something that is your dialogue, so that you really control the speed with which you get out of that room.
And you get a family member in there as well.
Yeah. Fantastic, you guys. Great. So now we will go ahead and transition off the stage, except for Dr. Yu. You're going to give us a Oh, there's a break now. Okay. Yeah, go get some coffee.